Madam, we are live now. Shall we start?
Yeah, sure.
So, good evening, doctors and all the participants. On behalf of Shield Healthcare, I welcome all in today's session on non-hormonal management of menopause. And our guest speaker is Dr. Nirmala Sarath, madam. So, before starting the session, it's our honor to introduce Madam Data MBBS, DGO, DNB, and Madam is attached in Kamala Hospital, Trichy, as a consultant OBGN and from Tamil Nadu. So with this short introduction, I request Madam to take over the session, and meanwhile I request all the participants for your active participation. And if you have any query, please post in our chat box. So once the talk will be over, we shall have a short discussion on this topic So thank you very much, Madam, for your valuable time on our platform Shield Connect, and over to you for further proceedings. Thank you very much.
Good evening, and thank you for your warm introduction. And today, the topic we have chosen is menopause. So this topic, why we are discussing today, because it's an often avoided and given not so importance, this topic. And this clinical entity is not so much considered in practical gynecology. But why is it so important, and why should we give a treatment to menopausal women with symptoms seeking treatment? That is what is the essence of this topic today. And what is menopause? Menopause is a normal natural event defined as the final menstrual period, which will be confirmed only after 1 year of cessation of menses completely. So this represents permanent cessation of menses resulting from loss of ovarian follicular function, usually due to aging. That is what is a natural process due to aging. So we must understand, we must make the patients understand that menopause is not a disease, but it is a natural transition from a normal reproductive age group phase of life to the post-reproductive phase of life, where in the reproductive age group, the estrogen, the female hormone, is in a very steady state, maintaining all the female reproductive as well as other organ functions, which is depleted because of the loss of ovarian follicles and going into depletion, causing all the deleterious effects in the female body. So what are the phases of menopause? Menopause is not a single on-time entity. It is a period culminating from the premenopause to the postmenopause. So menopause is the actual 1 year of absence of menses, but this is always a retrospective diagnosis. Only after 1 year of cessation of menses, we are able to diagnose, okay, this woman has gone into menopause. But what about the pre and post events happening around the menopause? So premenopause is the phase where it is a late reproductive age group, where all the hormonal depletion starts. So perimenopause is a stage 3 to 5 years before the final menses, and that which includes the final 1 year of absence of menses. So this 3 to 5 years before the last menses and the 1 year after the last menses, that is the perimenopause. And postmenopause is the phase that starts from the last menstrual period. This is the postmenopausal phase that we are focused on. So premenopause occurring prior to menopause. Menopause is the end of menstruation. Perimenopause is the physiological changes, end of reproductive capacity, and terminating with a climacteric. And postmenopause is that period after 12 months. The menopause terminology has been given by the straw staging system. That is the stages of reproductive aging workshop has given on these terminologies. So what are the endocrine changes that happen from at the reproductive age group? The FSH levels are normal. After that, the FSH levels start to rise, which is because of the depletion of the ovarian follicles. There's been negative feedback from the estrogen secretion is lacking, so that is why the FSH is increasing. And because of the follicular depletion, the anti-Mullerian hormone levels are decreasing. So that heralds the onset of menopause. And after the menopause, there is FSH levels are very high and AMH is very much decreased. So what is the prevalence of menopause in India? Globally, there are about postmenopausal women will reach by 1.2 billion by 2030. That is the estimate. So recently we have come to 8 billion. And it is estimated that about 1/8, almost 1/8 of this total population will be in the menopausal age group. That is how much is the so much of burden of the menopausal population that we are going to face in the world. So the prevalence of menopause symptoms, especially in India, in our part of the country, the prevalence of all the worldwide, not just in India, worldwide, 75% of menopausal women, perimenopausal women, experience hot flushes, which is the most common symptoms. Actually, with these symptoms, only patients come to us very often, and when they say amenorrhea as well as a combination of vasomotor symptoms, okay, we get to an idea that this patient is heading to menopause. And the other things are vasomotor symptoms, psychosocial like depression, loss of sleep, insomnia, flatulence, bone aches, joint aches, decrease in physical strength and stamina, drying of skin, and vulvovaginal atrophy symptoms. All these constitute the major symptoms of menopause. Worldwide, the age of menopause has almost become constant throughout the years, but the life expectancy has increased. That has not, the age of menopause has not changed much. It is like 42, 45, and now it is between 45 and 50. That has not changed much. But what has changed is the life expectancy of women. More than men, the longevity of women is more. So there are the more and more number of women entering menopause. The postmenopausal population is so much high, and that is why the need to address the problems of women in this age group. So, what are the hormone changes that happen in menopause? There is a decrease in the circulating estrogens because of the loss of ovarian follicular cells, and because of that, the ratio of estrogen falls down, estradiol falls down, and the level of androgen is the same almost because of the sparing of Pica cells and the ovarian stroma even during menopause. The follicular atresia happens, but the Pica and the stroma cells are maintained. Because of that, the androgen is continuously produced, thus the level of estrogen has come down. So that alters the ratio. And because the estrogen levels have come down, there is a decrease in the sex hormone binding globulin secretion from the liver, but there is increase in the peripheral aromatization of dihydroepiandrosterone to estrone, which is the menopausal estrogen, which is called the menopausal estrogen because it is less potent than the E2, that is estradiol. So in menopause, the E1 ratio is increased more than the E2. There is a reversal of the ratio between E2 and E1. There is no significant change in testosterone levels because of the stroma and Pica cells. So these are all the activities, maximum activities of estrogen in the body, scattered all throughout the body, especially in the brain, breast, and the genitourinary tract. These are the main things. But the other areas are the eye, heart and blood vessels, liver, skeleton, skin, and hair. So all these areas are going to respond in a poor way when they face with estrogen depletion. So how does the estrogen act on these areas? There are two estrogen receptors, the estrogen receptor alpha and estrogen receptor beta. Both are present in the ovary, CNS, and many other tissues as we have seen in the previous slide. So estrogen has both beneficial as well as deleterious effects on all the areas in the body wherever the receptors are seen. The estrogen depletion and how does it affect the menopausal health? There is short-term symptoms and long-term diseases. So short-term symptoms are the acute and most dramatic ones, which we experience in the very early stage of menopause, which will be very, very acute. As we see in the graph, there is a rapid decline in the estrogen levels. And this is during this period when the short-term symptoms occur and the long-term symptoms come little later on. So what are the acute symptoms? Hot flushes, most common and most early and most long-lived symptoms, we can say, hot flushes. And then mood, sleep, and acute cognitive changes. These happen really for a short time, and maybe after this, the woman psychologically and physically gets adapted to these changes. So it may not be bothersome after a period of time. And urogenital symptoms and skin changes, they start and they continue because the skin and urovaginal atrophy is going on and on and on with age, with increasing age and persistent hormone depletion. And then comes the long-term effects like cardiovascular diseases, osteoporosis, and cognitive decline, moving into Alzheimer's disease. So these are all the short and long-term effects of estrogen depletion. So what are the common symptoms? One by one, we will see. First is the vasomotor symptoms. These are recurrent transient episodes of warm sensation all over the body, especially in the upper body, accompanied by a flushing and intense heat in the upper body, followed by intense sweating associated with palpitations. So almost 75% of perimenopausal women experience this vasomotor symptoms. Almost no one can escape these symptoms in the onset of menopause. These are triggered by small increases in the core body temperature. Though the exact mechanism is not known, estrogen is found to have some effect on the thermostats located in the brain that control the body temperature. And because of the fluctuating levels of estrogen in the early period of menopause, there is a different control mechanisms that playing a role, and adjusting the thermostat is little bit accommodating to the thermostat changes. It's difficult for these women. So this is based on what kind of treatment the patient needs, depending on the symptom severity, the woman's comorbidities, whatever other diseases that she has, and her personal attitudes about taking medication for these symptoms, how long to continue, how much of medicines to take, and what will be the long-term effects and all that. So this is a physiological illustration of hot flushes. There is a sudden increase in the core body temperature that increases the blood flow to the skin, especially in the upper body. Vasodilatation is happening in the skin. That's why there's hot flushes and reddening of the face and the upper body, which then continues to produce a sweat. And because of the sweat, there is a sudden shivering and chillness felt by the woman. So there is increase in the heart rate. So palpitations are also bothersome for this woman. The other symptoms are vaginal dryness, vulvovaginal atrophy. 10 to 40% of perimenopausal women experience this kind of symptoms. Vasomotor symptoms may be there for some time till the body accommodates to the new change in the thermocontrol mechanisms. But with the vaginal dryness and skin changes, all these things, epithelial changes are there, permanent, and they will be continuing forever. Maybe the severity may the experience of the woman's attitude towards this symptoms arising out of dryness may alter, but the symptoms in the dryness is just the same. So what kind of advice that we can give to these patients are indulging in regular sexual activity using vaginal lubricants and moisturizers and local vaginal estrogen. So the local vaginal estrogen is said to be the most effective treatment modality in vulvovaginal atrophy. So this is a depiction of a normal vaginal epithelium in a premenopausal woman and a postmenopausal woman. So the beautiful squamous epithelium is stratified squamous epithelium, multi-layered with all the rugosity that we see, which is completely lost. All the rugose are completely lost in the low estrogenic state with thinning of the epithelium, which may lead to breaks in the vaginal epithelium and which may lead to postcoital bleeding also. So other issues are the sexual complaints, which decrease generally with the increasing age. Though the testosterone levels are not decreased, over a period of time, the woman may experience a reduction in the libido, and the dryness and irritation in the vagina cause them to lose interest in sexual life, causing a decline in the vaginal lubrication and elasticity. That's why they lose interest in sexual intercourse. So what we can advise is to have active sex life, use of lubricants and moisturizers, and local vaginal estrogen to maintain vaginal health. The non-hormonal therapies for menopause management. So we have seen the most common symptoms and the remedies that we have to offer, given the higher number of the menopausal population that we are facing. So the moment we talk about hormonal replacement therapy, which is being changed to menopausal hormone therapy now. Hormone replacement is not the terminology now, it is menopausal hormone therapy. And when we say the word hormone, there is a small trigger that runs along the minds of the patients. Usually they are not very receptive to the hormone treatments, because in this Google era, they are very well informed and always question us about hormones. Even in the women, young women, women with PCOS, women with the cycle irregularities, women with infertility, when we give hormone tablets that we are going to prescribe to you, then immediately there is what will be the side effects, what will be the side effects. So everyone is bothered about the side effects of hormonal management, even during, more so during the menopausal period. So what are the non-hormonal therapies that we can offer to these women? We have seen the problems that the menopausal women are going to face. So, first and foremost is osteoporosis. Osteoporosis, what we can do is advise them calcium and vitamin supplements and other treatments that may increase the bone mineral density, which faces a sharp decline when the woman passes the age of 35. So the treatment for osteoporosis actually starts around 30 to 40 years of age, where regular exercise and proper diet and proper weight management will go a very, very long way in the menopausal period, not just for the younger age group, but for the older period also. Now we are going to give good exercise to the body and good nutrition, then it will be of help in the menopausal age. So what women need is a daily intake of 1000 to 1200 milligram of elemental calcium, which will not be available to us in diet alone. So it needs supplementation that has to be made clear to the patients. And according to the daily requirements, we can plan the calcium supplementation. And vitamin D, we know, is very important for the absorption of calcium in the body. The daily requirement is around 800 to 1000 international units, especially in the postmenopausal period. So vitamin D supplementation by improving calcium absorption lowers the risk of fracture and falling in elderly patients. So postmenopausal women need a dietary calcium of 1000 to 1200 milligram. Sorry. So the other drugs, along with calcium and vitamin D, the other mainline drugs are the bisphosphonates. Bisphosphonates are very potent anti-resorptive agents that decrease the rate of bone turnover with proven efficacy in the prevention of vertebral and hip fractures, which we see very commonly in postmenopausal women. And because of the building of the dense bone by the use of bisphosphonates, which can last even after stopping the drug, which is even not so with estrogens. Even when we use estrogens, it provides protection only till the time of usage. You give estrogen for 3 months, 3 months your bones are protected. After 3 months, if you stop, again the bone resorption will start, and again will go back to the bone BMD will go back to the normal prior levels. But after using bisphosphonates, the effect is sustained, and we can even stop the drug for 2 or 3 years, but the bones may remain in good with a good bone mineral density. That's the advantage of bisphosphonates. That's why they are the first line of drugs in the management of osteoporosis. And they have some benefits in some cancers and may prevent bone metastasis from breast cancer. Maybe because they completely block the rate of bone turnover. And there are other selective estrogen receptor modulators like aloxafen, lasofoxafen, and bazidoxafen that reduce the risk of vertebral fracture in postmenopausal women with or without prevalent vertebral fractures. A combination of bazidoxafen and conjugated equine estrogen has been shown to preserve bone mineral density, but the bazidoxafen 20 milligram per day has profound effects on the breast and endometrium. Also, it has an agonistic activity, estrogen agonist-antagonist activity, and it may exert an agonist activity on the breast and endometrium, which we have to be careful about. Raloxifene is also indicated for reduction in risk of invasive breast cancer in postmenopausal women with osteoporosis. These are the additional benefits. The other drugs available for osteoporosis are parathyroid hormone, calcitonin, and strontium, etc. And the next group of drugs are for the vasomotor symptoms. The most commonly used drugs are the selective serotonin reuptake inhibitors and selective noradrenaline reuptake inhibitors. And then comes the gabapentin. They are effective in reducing vasomotor symptoms in short-term studies. Their long-term safety needs further evaluation. So they are, even now, they are used as off-label drugs only. Paroxetine 7.5 milligram per day may be helpful in reducing the symptoms of hot flushes, but the long-term efficacy needs to be analyzed. And people with already who are depressed, already who are taking the antidepressants, then they may have an additional load of depression because of the drug intake and all that. So we always need to take care of other comorbidities of the patient and other drugs that she is taking and the possible drug interactions that they may have while using all these drugs. So high quality studies have not supported the efficacy of complementary or OTC therapies in reducing severity or frequency of hot flushes or night sweats. And whatever herbal things that we commonly use, the soil products, are not superior to placebo. They have not been proven to be effective. increased interstitial soy acid levels. That is over the years, it is supposed to be it is promoted as a weaker estrogen, but it is not so. Over many studies that have been conducted, the soy acid levels have proved to be very ineffective. They are not better than any of the placebos. They are not suitable alternative to hormonal therapy. So what is an ideal menopause solution? You do not want a hormone. You have to everything you have to give us a non-hormone. Non-hormone so far we have only soy isoflavones and SSRIs and SNRIs, which come with an array of all the side effects that they provide. So what could be an ideal menopause solution? It could be a molecule which can regulate the estrogen, endogenous estrogen, more to the non-reproductive organs like the brain, the bones, the heart, the non-reproductive organs, and control the level of estrogen to the genital organs like the breast, endometrium, reproductive organs. So, if we can maintain that balance, then that would be the ideal drug in managing menopause. It should offer symptom relief as good as a hormone therapy. It should be the symptom relief should be equal to the hormone therapy, but should it be without the risk of cancer or thromboembolism that the hormone therapy provides. So what we need is a upregulation of estrogen receptors in non-reproductive organs and downregulation in the reproductive organs, so that the fear of without the fear of inducing a cancer, we can treat the menopausal symptoms of the woman. So some herbs which have shown good results in this area have been cinnamic acid, shamsicide methyl ester, and nodaquinone. These are available in these herbs: Sinanchum wilfordii, Flambosis ambosa, and Angelica gigas. So these molecules mainly are used in China and Korea. And nowadays we are looking to Korea for all the beauty products and all that. The K brand has been so popular, not just for the stage pop, and it's also for the beauty products and this medicine. So they have been in China and Korea, there have been studies available for it since a long time using these herbs, and they have shown to give adequate optimum results. So that is this product estrogen is made from these ingredients, and this has the same quality of regulating the estrogen affinity to the estrogen receptors. It upregulates the estrogen affinity of receptors present in the vascular endothelium, CNS, bone, which is a favorable beneficial effect that we expect from a menopause treatment agent, which also not just it promotes the good activities and benefits, it also downregulates, it reduces the affinity of the receptors present on the breast and endometrium. There is no proliferation of MCF7 cells, which are the cell lines found in the CA breast patients, which are so important in the if the estrogen may promote this MCF7 cell lines so as to cause CA breast. So there is no risk of cancer in using this medicine. So it is a non-estrogenic hormone regulator. It is not a hormone, but it just regulates the receptors. So it does not have affinity to the receptor, but it upregulates and downregulates the affinity of the receptors present in various cells. Agonist antagonist action on the receptor affinity. That is what the benefit it has. So what are the results by using this drug? The vaginal dryness, hot flushes, mood swings, bone pains, which are the acute symptoms, short-term symptoms that we have seen in the early menopause. They are relieved while using it within 7 to 14 days, which is a very faster onset and which is very sustained for this period, the first 3 to 4 months of time. So that is what we need more coverage. It is what these are the more bothersome symptoms of the any menopausal woman. So this coverage is being given by the drug. So the study concluded subjects on estrogen 100 group had significant reduction from 10 out of 12 Kupperman index symptoms. Kupperman index is the grouping of symptoms, most common symptoms that we menopausal women experience, and total score is given. So after that score, 12 symptoms out of 10 out of 12 symptoms have been relieved by use of estrogen. So on the long-term studies have shown that the resorptive elements in the bone, like the osteocalcin and alkaline phosphates, they all decrease, and there is a significant increase in the bone mineral density after the use of 1 year. So it is having a not just on the short-term symptoms, but it is having a beautiful effect on the long-term morbidity as well. So the evaluation of efficacy and safety of this drug on menopausal symptoms in a 12 weeks multi-center trial study has clearly shown that the symptoms have improved over placebo. It has a very, very significant beneficial effect over placebo in a duration of 12 weeks assessment. ECG for 12 weeks statistically significantly improved the quality of life. The other symptoms that improve were hot flush and night sweats, nervousness, vaginal dryness, which are the most important and most dramatic symptoms that happen in early menopause. And added to that, there were no adverse effects reported after the use of the estrogen from the estrogen group. It is found to be safe and effective herbal formula that can improve women's quality of life and various menopausal symptoms. And there was no toxicity, no mortality, no general symptoms like body weight and changes were observed. So these are all very important. Every woman will ask, even if you give an iron tablet, they will ask, doctor will like, won't I gain weight? This is what is the first question. Even if you give a multivitamin, any woman asks. So there is no significant body change, and this seems to be the best hormonal therapy that we can give. It is not a hormone. It is not very ineffective. Studies have proven that this is very effective on the short-term symptoms as well as the long-term morbidity, menopausal morbidity. So, what are the other drugs available? Venlafaxine, desvenlafaxine. These are used for hot flushes and all that. There may be increase in the there may be improvement in the symptoms, but they cause elevated blood pressure and temporary side effects, hot flushes. All these things can happen, and when we stop, there can be a rebound effect of hot flushes when we stop these medicines. And the other ones, SSRIs and SNRIs, fluoxetine, paroxetine, they may have a better profile on the hot flushes and mood swings, depression, and all that. Decreased libido, insomnia, all that can improve, but they may aggravate depression and all that. And gabapentin is an off-label, commonly used off-label drug. It will be useful in patients who are having insomnia also. Clonidine was used before as a first-line drug in for hot flushes, but now because of the profound side effects, it will be pushed to the side. So what are the other things that we can tell the women on a lighter note without any drugs? What are the other non-pharmacological modifications that we can advise? Regular exercise reduces cardiovascular and total mortality. Not just the cardiovascular mortality, it improves the sense of balance and the risk of falling, and because of that, the fractures secondary to falling, all these will be prevented. It helps balance the body weight, which will go a long way in management of osteoporosis and the prevention of diseases like diabetes and hypertension. When the BMD, when the bone mineral density tends to take a sharp downturn around the age of 35, exercise is the one that will keep the lean muscle mass in a balance, and it will improve the bone health also. So this we have to start even from the middle age, even in the pre-menopausal age, we have to start, and we have to advise the patients on starting on giving the importance of physical exercise. And this, coupled with the release of endorphins, has helped. It is claimed to improve the cognitive health also, mental health also. That may go a long way in preventing or delaying the Alzheimer's disease. So not just the cardiovascular benefits, the other benefits also there in doing exercises, which have to be taken up in a more serious note, even in the premenopausal stage itself. The benefits of exercise far outweigh the possible adverse consequences. The optimal exercise prescription is at least 150 minutes of moderate intensity exercise per week. 2 additional weekly sessions of resistance exercise may provide further benefit, like the lifting, weightlifting, and all that. The resistance exercise may help in maintaining the bone mass as well as the lean muscle mass. The recommended intensity of aerobic activity should take into account the older adults' aerobic fitness also. So we cannot say go walk for everybody. You have to think about the comorbidity, the area they live in, who can accompany them. All those things we have to think, and we have to advise them on the importance of exercise. So all these things constitute the non-hormonal management of menopause, not just the medicines, whether it is hormone or non-hormone, or the side effects, or whether or not there are not, and long-term side effects are not just these things. The dietary modification, exercises, and then focus on physical as well as mental health, not just for today, but for the future also. So for all these things, we have to the most population of women that we see in our clinics mostly are women in the late reproductive age group. So from them to them, we can advise. For young women, PCOS they're coming. So there we start giving the importance of physical activity, decreasing the insulin resistance and all that. So the same way, we should always emphasize all the age group women to have regular physical exercises to maintain their good health. Diet is the other important thing. So several servings per day of fruits and vegetables, whole grain fibers, fish twice per week, and low total fat. All this should be given importance, and consumption of salt should be very much reduced. And the weight loss, when the weight loss promotion is promoted, for patients with PCOS, we advise them. Even with the patients with infertility for obese, we always tell them to lose weight and come. When you lose even at least 5 to 10% of your weight, the treatment brings about more dividends, better dividends. So that's what we say, even for younger women. The same holds good for menopausal women also. So when there is a weight loss of at least 5 to 10%, there is a sufficient improvement in insulin resistance, thereby decreasing diabetes and hypertension, and then secondary to that, the cardiovascular mobility also. So keeping all this in mind, the importance of diet and maintaining a good weight and daily physical activity, all this should be emphasized to these perimenopausal as well as the postmenopausal women. So we come to the conclusion, and I thank you all for your patient listening and the opportunity given to me to talk on this topic. Thank you.
Thank you very much, ma'am. Just give me 1 minute time to check if any question is there, ma'am.
Sure.
Madam, one question is, in case of this menopause management, what will be the ideal exactly means when to choose this HRT and when to choose non-hormonal treatment? So is there any specific conditions that in case you can use HRT and non-HRT treatment?
Yes, hormonal therapy we have to use only in women who are less than 60 years of age, and the onset of the whole menopausal life should not be more than 10 years. Suppose if a patient attains menopause at 45 years, then if she comes after 55, at the age of 58 or 60, there is no use of starting hormone therapy. Hormone therapy is best efficacious if it is started less than 10 years of attaining menopause, and overall the woman should be less than 60 years of age, because after 60 years of age, there is no significant difference in cardiovascular morbidity and other life comorbidities. So HRT may not be beneficial in that age group. That is one thing. And the approved treatment as hormone therapy as a treatment has been approved only for hot flushes as well as vulvovaginal atrophy. Even for prevention or treatment of osteoporosis, estrogen is not the first line drug. As I said, the bisphosphonates are the first line drugs for osteoporosis. So these are the things that need to be considered. Not just menopause give the estrogen. It's not like that. We have to think about all the patient's complaints, patient's educational status, their ability to understand the pros and cons of hormone therapy, why it should be given on a short-term basis on a minimum dose, why it should be given, why it should not be taken over the counter, why a proper review with the physician is always required while on a hormone therapy. All these things need to be considered before starting a woman on hormone therapy.
And in case of surgically induced menopause, so HRT is means optimum, or without HRT you can opt for something else?
HRT is of most beneficial to the woman who is undergoing surgical menopause, because they are undergoing menopause at an earlier age where the receptors are active and they need those estrogen molecules in their own natural form. So those kind of women definitely require hormonal therapy. There, the non-hormonal therapy is not much of use. It's not as efficacious as hormone therapy. No, nothing can replace estrogen. So estrogen will be the best choice. So there it holds very important. Non-hormonal therapy is of more significance in women undergoing surgical menopause. And that we can continue until the natural age of menopause. Say, for example, 48 or 50. Up to that age, we can continue hormonal therapy at its lowest possible dose, which will be of benefit to the woman. And these women need to be followed up very regularly for the development of breast cancer. And when the uterus is not there, it's okay. When the uterus is intact, then we have to look for the endometrial changes also. And other comorbidities, if she has, what is the effect on this lipid profile and metabolic effect of this hormone therapy? All these have to be considered and screened every year.
Thank you, madam. And last question is, ma'am, how long can we safely use this HRT?
And that's what, in a case of surgical menopause, we can use up to the age of natural menopause, up to 48 or 50. Though there is no definite deadline on up to this age only you have to use, depending on the patient's condition, patient's acceptance, and patient's response to hormonal therapy, we can choose, but usually not beyond 60 years of age. Usually not beyond 60 years of age.
So thank you very much, madam. I could not find anything else. So thank you very much for your valuable time to discuss a very important topic in our platform Shield Connect. And in future also, we will be looking forward for some valuable session with you. Yeah. So thank you very much, madam. Have a good day.
Thank you. Thank you so much.
Thank you very much, ma'am. Thank you very much.
Thank you.
Yes, ma'am.
Madam, you can.